I had a unique situation of having an ex-NFL football player needing a revision surgery. He had a microdiscectomy of L3-4 and L4-5 many years ago when he was playing football in the NFL. And he did well at that point, but unfortunately developed severe disc space collapse at both those levels, resulting in severe foraminal stenosis. And the unique situation is that his body habitus was, quite frankly, very large. He was a lineman in the NFL, and he's still very large to this day. And so because of the situation, I said, he needs a minimally invasive decompression and fusion, and I have to pick the instrumentation that can allow minimal disruption to the neural elements and disruption of the scar tissue, as well as provide a large anterior column support. I thought this patient would be a perfect candidate for a minimally invasive TLIF using a FlareHawk interbody cage. And why was a FlareHawk interbody cage so crucial for this operation? Well, number one, it provides a very large surface area for fusion mass. So I'm dealing with a patient that's 300 pounds, rock solid muscle, needing a 2-level fusion. So because of the FlareHawk's interbody cage being so large in surface area, it provides a large anterior column structural stability to increase the surface area, thereby increasing fusion rates. Number two, it goes in at a small size. So with the scar tissue from the prior surgeries, I was less concerned about irritation of the exiting nerve root as we passed a graft by. So FlareHawk's unique in that it inserts at a very small size, but then expands open both height-wise as well as medial-lateral to provide that large footprint, in addition to the lordosis that it provides. Because of the porosity of the cage itself, allow for dispersion of bone graft circumferentially around the cage, so left and right, and obviously right up against the cephalad and caudal vertebral body, allows for a lot more bone graft placement. And it's actually quite fascinating how much bone graft you can insert into the disc space. And in this patient, an example that I gave you, I actually was able to pack 20 cc's of bone graft in the disc space in each level. And that's in a disc space that was completely collapsed, almost bone-on-bone disc degeneration at L3-4 and L4-5. So that's quite a large bit of bone graft material. So the patient on MRI had significant foraminal stenosis, and this was multifactorial. It was partly due to vertical disc space height collapse from the disc degeneration, secondarily from scar tissue from the prior microdiscectomies at L3-4 and 4-5. In addition to that, he had quite a bit of spondylotic degenerative changes with facet joint arthrosis and ligament flavum hypertrophy contributing to the stenosis. And on top of that, he was developing segmental asymmetric disc space collapse. But of X-rays, you can see that we placed a large footprint interbody cage, midline location, and we're able to pack in quite a bit of bone graft. As I said before, I got in a total of 20 cc's per level, which is huge. I've never, in the 5 years I've been doing minimally invasive TLIFs, have ever been able to put in that much bone graft in an inner space after doing a MIS TLIF, ever. That's the most I've ever gotten. So it's quite remarkable how much bone graft we can actually pack in there. And obviously, as we know, one of the major goals of this operation is to get it to fuse. Patient's doing fabulous. He's now 3 months after surgery. He went home post-operative day 1, and I actually just saw him last week for his 3-month follow-up, and he wanted to run up and down the halls and do football poses for me to show how good he's doing, getting down in a tripod squat. So it's pretty impressive how good he's doing. But you know, using these minimally invasive techniques with the solid construct that we have, I think it facilitates recovery and to get people back in action as soon as possible.